Hello, good morning and good afternoon to those joining us from East Coast. I'm Ankit Sangvi, Executive Director at Texas Health Institute, and want to extend my warm welcome and appreciation for joining us for today's webinar. I'm excited for today's discussion and to unveil the findings from our new report, Advancing Oral Health Equity in Texas, a community-driven approach. Before I dive into today's discussion, just a quick couple of housekeeping items. We do have a dedicated time for Q&A at the end of this webinar, and encourage all attendees to use the Q&A box towards the bottom of your screen to ask questions to today's panelist. This webinar is recorded, and the link to the recording with the follow-up evaluation and the link to download the full report will be subsequently sent out after today's webinar. And with that, I am ready to dive into today's discussion. Want to extend a welcome to my fellow co-panelist, Blair Williams. If we can move to the next slide. Blair Williams, Director for Health Equity Research and Innovation at Texas Health Institute, who will unveil the findings and takeaways from our report. And honored to have been joined by Dr. Natalia Chalmers, Chief Dental Officer at Center for Medicare and Medicaid Services, to share her reflections and really how these findings from this report align with the efforts at nationally at CMS and other agencies. Next slide. While Blair and I have the honor to share the findings of this report, the project wouldn't have been possible without the amazing team at the Texas Health Institute. And I just want to share my appreciation and gratitude for each one of them for sharing their commitment, time, expertise, and more so their creativity and intentionality as we pursued this undertaking. Next slide. So before we unveil the report and share our findings and key takeaways or the path forward, I think it's important to contextualize why oral health equity, and where we are coming from. So for those of you not familiar, Texas Health Institute is an independent public health institute here in Texas with a vision for healthy people, healthy communities, and a mission for advancing the health of all. Our work is focused on the three priorities of advancing health systems transformation for whole person and community-centered healthcare for all, strengthening public health infrastructure to be responsive to the needs and crises of the 21st century, and promoting healthy communities to ensure the systems, policies, and environments are in place to give fair opportunity for everyone to thrive. However, what cuts across these priorities and is at the heart of all of our work is our commitment to health equity. That is, ensuring everyone has the opportunities they need, free from barriers, to pursue their best health. It centers everything we do, and more so, how do we do it here at THI? And in that vein, speaking of equity, let's talk about oral health equity. Next slide. Oral health is certainly not something that is new or is a part of a new undertaking at THI. However, with our updated strategic framework and a commitment to oral health equity a couple of years ago, we had a pause and a sense of reflection on our journey as an organization across all of our work, which included oral health. And while we have been proud to play our part as a public health institute in elevating the role and recognition of oral health as a public health issue, and the work we have done through the years, it's always been with the intent of what can we do, what does the system look like, where do trends indicate needs or opportunities, and sharing that with the audiences we have had an opportunity to work with. And what's really unique and inspiring for the undertaking and this pursuit that's been part of our work for a good part of the last couple of years, and the first step of that we are unveiling today, is really flipping the story on its head and putting those communities that we seek to benefit, serve through our work through this years, putting them at the heart of it. So instead of asking or answering the question, what do they need? We led this project with the idea of what do they need from us? What are their experiences of their current system? What are their aspirations from the current system? And proud to have been able to do this, and wouldn't have been possible without the funding support by CareQuest Institute for Oral Health to support us in our journey of advancing oral health equity for all Texans. And with that, without further ado, now it's my honor to officially unveil our report on advancing oral health equity in Texas. And with that, it's my honor to also introduce Blair Williams to unveil the key findings with you and share some perspectives, some context that we hope you will benefit in terms of your work in advancing oral health and health equity, but also invite you all to engage with us on ideas, policies, changes, or systemic shift that need to occur to realize the vision of oral health equity for all Texans and beyond. With that, Blair, on to you.
Thank you, Ankit. It is an honor and privilege to share our report, Advancing Oral Health Equity in Texas, a community-driven approach. In our time today, I will present high-level information from this report. And for more information on our community-engaged methodology and priority areas of affordability, availability, and accessibility, person-centered care delivery and aligned performance measures, and dental medical integration, I encourage you to view the full report that will be made available in the chat. With funding support from CareQuest Institute, THI engaged 8 community-based organizations as research partners to assess and contextualize oral health disparities by age, race and ethnicity, disability status, sexual orientation, gender identity, and geography. As research and engagement partners, the CBOs received THI's training and support to recruit participants, facilitate focus groups within their respective communities, and attend a sense-making session to validate takeaways, contextualize findings, and discuss any study limitations. Our research partners are located throughout the state, as indicated here on the map. And starting at the top and working clockwise, I'll list each research partner. Tri-County Community Action in East Texas, Maternal Health Equity Collaborative, Black Mamas ATX in Austin, Texas Parent to Parent, a statewide organization based in Austin, Equality Texas, a statewide organization based in Austin, Area Health Education Center in Laredo, Acres Home Community Advocacy Group in Houston, Cancer and Chronic Disease Consortium in El Paso, and Texas Impact in West and North Texas. Collectively, the 8 CBOs listed here conducted 10 focus groups with a total of 96 participants representing their respective communities. THI would like to thank the community partners and CBOs for sharing their perspectives for the advancement of oral health equity in Texas and in the United States. Their community voices are the driving force of this report. To provide additional context, we also interviewed 8 key informants who are leading oral health efforts across the state of Texas. Their insights provided programmatic systems and political context. We also sourced literature and publicly available data for additional context. And so for more information about the methodology, the data sources that we used, and study limitations, I encourage you to view the full report. Next, we invite you to hear directly from our community partners and members, to hear their stories directly from them, a vision for oral health equity.
Was getting cavities right on over here on my, so I couldn't smile. I didn't want to smile because every time that I smile, everybody would tell me you have something in your teeth. I know what I had on my teeth. It was cavities. I just didn't have the money or the insurance to get it treated. And it went like that for like years and years. It was amazing to come out of the dentist when I finally had the job and the access to healthcare to going to the dentist, getting those cavities taken care of, and come out and be able to just smile without being self-conscious.
There was one individual that shared a lot about their journey through oral health. They suffered a lot from many issues, many dental issues, and unfortunately they do not have like insurance. That individual suffered a lot for many years to the point that for one period of time they were without their dentures.
What good oral care means for your self-esteem in a culture where you're always trying to present yourself in a good light, especially if you have a disability. It can mean a lot for your ability to make friends, to get jobs.
I had a tooth that was extracted without, I had anesthesia, but it wasn't enough. So I felt every bit of the pain there. I'm right now, I'm afraid to go to the dentist. I'm really afraid of the dentist office.
It's important to me that I feel listened to and I feel heard and respected.
You stay in the community that you're serving. Be there for the people.
We made sure that we put mental health, eye care, dental care, and hearing aids and long-term care in the proposition. So having a system that allows everybody, regardless of your race, gender, regardless of your economic or your bank account, still have access to these necessities that are basic human rights.
To our community participants and partners, we thank you. We thank you for sharing your stories and your perspectives with us, and we thank you for sharing your time with us. And we hope that we are able to respectfully lift your voices and your perspectives today and in our report. Today, I'll present, of course, the key findings from the report, and it's drawn from community, key informants, and formal evidence. And the synthesis of this underscores the need for continued efforts and system transformation, primarily in the areas of racial equity, in the access to oral health care and career opportunities to support workforce diversity, timely access to person-centered care that honors shared decision-making between patient and provider, and is culturally competent and linguistically appropriate, and integrated dental medical care to improve care coordination across disciplines. These findings are translated into 3 priority areas of action: affordability, availability, and accessibility, person-centered care delivery and measures, and dental and medical integration. Priority 1 is based on consistent themes that we heard from community voices: common barriers of cost, distance, time, physical barriers, and feelings of judgment that all hindered access to oral health care. And these common barriers are categorized into 3 distinct themes: affordability, availability, and accessibility. Affordability includes barriers such as cost. For example, do I need groceries for the week, or do my teeth take 9 out of 10 times, the groceries, the bills, the rent is always going to take priority. Next, availability includes barriers such as distance and time. For participants living in rural areas, it was common to hear of 3, 4, or 5-hour drives to get needed care, and waiting several months for coordinated care for those with specialized healthcare needs, or in border communities to simply go to Mexico for needed oral health care. Accessibility includes physical barriers and other barriers, such as feeling unwelcomed or judged. For example, the way that information is presented to people is so important because I've seen people walk away in tears on how they felt just trying to get the care that they needed. Similar stories came from focus group participants representing patients with disabilities and members of the LGBT+ community. These 3 themes are consistent with key informant interviews and evidence. And from publicly available data, an estimated 11 million Texans don't visit a dentist each year. And while many factors can contribute to this estimated number, groups more likely to experience barriers to oral health care include members of low-income households, Texans living in rural and border communities, individuals or caregivers of individuals with a disability, and individuals who have past experiences of feeling judged or unwelcome at past visits. The themes of affordability, availability, and accessibility continue on into the next priority. Building on priority 1, priority 2 is based on consistent themes heard from community voices, a shared desire for dignity, respect, and compassion. Translating these findings into action, opportunities emerge to improve workforce readiness and measuring progress. Workforce readiness includes building workforce capacity and diversity. For example, if there's more diversity in dental, it's going to help remove some of the stigma and maybe help some trust where there hasn't been trust in the past, but there's still so much more than just that. And I think it's not going to fix it all. That's from a focus group participant. Next, similar, we also heard from focus group participants that we want providers that look like us. And next is measuring progress. While the quote featured here is from a key informant, this quote speaks to a need for systems alignment to measure and incentivize the delivery of person-centered care. For example, discussions and contracts with managed care organizations that integrate the value of taking care of diverse populations and trying to improve health equity have not been fully addressed. In addition to these themes, the population of Texas is rapidly growing. This population growth, combined with the anticipated workforce shortages, present opportunities to improve the capacity for and the delivery of person-centered oral health care. At present, population health measures for the delivery of person-centered oral health care are not yet operationalized across systems. Aligned health measures may improve the delivery, finance, and accountability of person-centered care. Efforts to improve workforce readiness and align data systems may be impacted by current and anticipated workforce shortages. In this map of public health regions across Texas, the North Texas and Gulf Coast regions, shaded in purple, are the only regions where the supply of dentists are anticipated to exceed demand. In contrast, the areas that are shaded in teal are areas of anticipated workforce shortages for dentists. Building on priorities 1 and 2, priority 3 is based on consistent themes from community voices, calling for an integration of dental and medical care, primarily in the areas of insurance coverage and interprofessional collaboration. Insurance coverage includes aligned dental and medical care coverage, truly solidifying the connection between oral health and overall health. For example, I think what would make it easier would be that the health insurance companies would recognize your mouth and your eyes are part of your body, and it should all be insurance for your body and be done with it. Interprofessional collaboration includes care coordination. In this abbreviated quote, we see challenges of coordinating care, insurance, and office visits during pregnancy, a time where oral health is crucial for both mother and baby. When I had insurance through my job, they would cover me going once a year for annual cleaning. When COVID hit, I was pregnant with my first son and got put on Medicaid. I would go, especially while pregnant, because your teeth decay more. I noticed a lot less dentist offices are taking Medicaid. It was like trying to find an office that is close, takes Medicaid, and is available when I need it to be available. This quote also underscores the importance of affordable, available, and accessible person-centered care during pregnancy. These findings express the connection between oral health and overall health. Unmet dental health needs may result in the overuse of emergency departments, and this divide presents a barrier to the delivery of affordable, available, and accessible person-centered oral health care for children, those with specialized healthcare needs or those living in rural areas. The need for dental medical integration is echoed in key informant interviews and evidence. From participants and key informants, we heard of stories of 6 to 9 month waiting lists for patients with specialized healthcare needs, worsening health conditions delayed due to costs, and emergency room visits. And in 2019, over 1 million adults in Texas had at least one recent visit to the emergency room for a dental problem. And in Texas, adults with disabilities are nearly twice as likely to visit the emergency room for a dental problem. So in summary, this again is a high-level overview of what's in the full report. The priority areas are listed here on the slide, and I encourage you to view the full report for more information. And before I turn it over to Ankit, I'll present this last slide that really summarizes the areas of action in the areas of policy, community-driven approaches, and aligned data systems. Advancing policy interventions includes addressing barriers to that affordable, available, and accessible oral health care, workforce readiness, diversity, and the dental and medical integration. The community-driven approaches, which really require a co-creation and partnership with the community to create strategies and solutions, and aligned data systems, where all systems are working together to have data available and hold dental providers accountable for person-centered care. And with that, I will turn it over to Ankit to introduce our next speaker. Thank you very much.
Thank you, Blair. Thank you, Blair, for your expertise, your passion and commitment to oral health equity. Again, there is so much to unpack. Certainly for those of us in the field of oral health equity, while some of these findings may not be surprising, I hope that the stories that we were able to capture and share through this undertaking contextualize your efforts and inspire us as a collective to really take this forward and move from conversation to action. On behalf of THI, I express my commitment in walking that line and walking with you in this journey forward. But now it's my honor to introduce Dr. Natalia Chalmers, again, Chief Dental Officer at the Center for Medicare and Medicaid Services, to share her reflections from this report, but more importantly, how many of these findings and the recommendations that we received from our community members tie into the efforts she's leading at CMS, as well as with other federal and national partners, or uplifting efforts for things that are working or may run in parallel with other states across the country. Before I invite her to share, just for those of you not aware, Dr. Chalmers is a board-certified pediatric dentist, an oral health policy expert, and a public health advocate with over 20 years of clinical research, industry, and regulatory experience prior to her role at CMS. She also served as the dental officer for the U.S. Food and Drug Administration. And again, someone, to say the least, has been my inspiration for the work I've had a chance to be a part of when it comes to improving oral health and oral health equity. Again, Dr. Chalmers, it's an honor to have you join us. And with that, the floor is yours.
Thank you, Dr. Sangavi, and thank you, Blair, for sharing this very insightful report. It was moving to hear the perspective of the beneficiaries and directly from them. And I look forward to engaging in more questions and answers. But as Dr. Sangavi said, I thought I would share with you from a national perspective the efforts around oral health across all of our programs. And how deeply they align with what you found. So let me do this. Quick thumbs up that you can see this. Great. All right. Let's start with level setting about the programs at CMS. Every day, CMS ensures that 159 million people in the U.S. have health coverage, 88.4 million through Medicaid and CHIP. With broad federal guidelines, the states have a lot of flexibility of how they administer the program. Medicare, 66 million enrollees, about half and half in fee-for-service and Medicare Advantage. And then 16 million consumers. The latest numbers are very encouraging, 21 million consumers access Marketplace. And we have to recognize that about 12 million people are both eligible for Medicaid and Medicare. CMS vision is that we serve the public as a trusted partner and steward dedicated to advancing health equity, expanding coverage, and improving health outcomes. And these are not in random order, focusing on advancing health equity by addressing the health disparities that underlie in our health system. And you've shined light on some of these when it comes to oral health. Expanding access, building on the Affordable Care Act to expand access to quality, affordable health coverage, engaging with partners, this is why I'm here today, driving innovation, protecting our programs, and fostering excellence for CMS to be a great place of work. Last year, CMS launched the Oral Health Cross-Cutting Initiative that joins other cross-cutting initiatives. These are multi-year, multi-component initiatives. And for the oral health one, we will consider all opportunities to extend access to oral health coverage using our existing authorities and health plan flexibilities. As you can see and note, many of these issues don't just touch one program. For example, rural health, behavioral health, this is not a Medicaid or Medicare program. And the same is true for the Oral Health Cross-Cutting Initiative, working across the agency to advance oral health for all of our beneficiaries in a whole person-centered care approach. some of your findings highlighted what we've known for a long time, that the dental delivery system remains siloed from the rest of healthcare. And if you're a patient who has coverage, you may be a well-established patient who can go and see their dentist when they need to, or you're one of these patients who only shows up when there is an emergency. And then if you don't have access to the dental delivery system, you are most likely, and you highlighted also in your study, that people will end up in the emergency department, either as a single visit or repeated visits. And sometimes their condition is so severe, they have to be admitted. And there is, of course, a huge price difference between the cost of care in the emergency department versus inpatient. Ambulatory surgical centers are very important point of access to care, but for many children, the schools are critical point of access, not only for nutritional services, but also for health services, oral health included. And of course, we also know the charity events that happen once a year that people can access care. But we have to recognize, and I think this came also in some of your studies, that these two systems are not connecting, and there is a huge health information technology divide that prevents the integration and coordination of care that we heard was so desired. There's lack of use of diagnostic coding, right? We have a lot of challenges to solve to integrate the communication between the providers. And you see that reflected in our human-centered design findings. I'll share in a minute. But I think it's also very important to look at what is the proportion of the population in each state that's enrolled in Medicaid and CHIP. And I hope you can appreciate from this map that it varies dramatically across the US. In some states, that is only less than 22% of the whole population in the state, but in other states, it's as high as 40%. And so this presents, a challenge and an opportunity, but really the realization that every program has its own unique challenges when it comes to delivering the healthcare the beneficiaries need. And now we're going to look at this, but only for children. So the next question is, how many of the children in each state are enrolled? And you see a very different picture. And the way you would read this is that in some states, about a quarter of the children are enrolled in Medicaid. And in other states, that is close to 80% of the children are enrolled in Medicaid. Why is this important? When we talk about oral health services, right, for our beneficiaries, that touches 80% of the children in that state. But for children, and you will look at this in a second, access to any healthcare services is very much driven by their caregiver, the parents, and their access to care. And so let's look at how many, what's the proportion of the adults in a state that is enrolled in Medicaid. And that looks very different too. In some states, it's less than 12%, and in other states, from the adult population, it's as high as 30%. Now, again, I said, why is this important? Because for children, access to many of these dental services will require a parent who is aware and has themselves access to dental care. And I mentioned the duals in the beginning, but let's also recognize that as a proportion of all the Medicaid beneficiaries, there is a huge variation of how many of them are duals. In some states as low as 4%, and in other states as high as 20%. Again, another challenge and an opportunity to coordinate care between two programs. But when we think about accessing dental services and the coordination of care, I think that came very clear in your report, it's also important to recognize that in a given year, 121 million adults, people in the US, access both dental and medical services, but a huge proportion only access medical services. And there is a proportion that only access dental services, presenting a huge opportunity for integrating basic healthcare communication and screening education on both sides of this, at the dental office and at the medical office. And of course, recognizing that we still have a lot of people who don't have access to any care. And I would just highlight here that although they may have both medical and dental visits, that doesn't mean that the care is coordinated and integrated. Often, again, this happens in silos. Initially, when these findings were presented, people said, oh, well, this is only true for commercially insured patients. So we actually looked at that with my colleagues at the Agency for Healthcare Research and Quality and Indian Health Service. And while this is another way of looking at that Venn diagram, overall 9% only see a dentist, about 37% see a dental and a medical provider, and 33% see a medical provider. What is very remarkable is if you have private medical with dental, the bar that overlaps between dental and medical provider obviously is the highest. So coverage is really, really key in order to accessing care. And the private medical without dental resembles the public-only space, but in the public-only space, we see actually higher rates of visiting both a dental and a medical provider. And of course, we are all aware that the oral health diseases have many inflammatory comorbidities from Alzheimer's disease, type 2 diabetes, cardiovascular disease. We know the science has advanced, and we know how this happens through bacteremia, the oropharyngeal, and the orodigestive dissemination. Huge importance for maternal outcomes and the impact of poor oral health and periodontal disease on pregnancy outcomes. Now, allow me to share the findings from our human-centered designs, where we also reached out to beneficiaries, providers, and oral health stakeholders at the state level in the human-centered design to ask what are these barriers to healthcare. We talked to our patients and providers, and I also hope that this is a reflection of their voice and a visual summary of their experience. And as I said, this work supports the cross-cutting initiative at CMS dedicated to oral health. The first image I will share is very busy. You'll have access to it so you can study it in detail, but it highlights these barriers in three major categories. Our stakeholders identified those that can be addressed or faced by government, the other one by patients, and we'll dive into these in more detail, and the third one was by the providers. So let's dive by those, first direct quotes from the patients. I mean, we heard almost verbatim this in the video you shared, that it takes time to find a specialist, sometimes up to 6 months. As many of you know, dental pain doesn't wait. So 6 months is a long time if one has oral health needs. We heard from the providers, they're tired, they can hire an assistant, or this could be, hygienist or front desk, you name it. The workforce shortages are significant, they're closing clinics. We heard from the managers that they can't keep the clinics open with the reimbursement rates. And we also heard from the emergency providers, care providers, that here is a prescription for antibiotics and the pain. You need to find a dental provider. We also heard from the patients that the time it takes to get to an office can be a burden if they're working 3 or 4 jobs. And then we heard from stakeholders how important data is for them to understand what are the barriers and challenges and how to build a better system. So data and building a better system really go hand in hand. More specifically, we heard that states during the legislation that allocate more funding to expand oral health care benefits, because this can be done through this pathway. We heard about the role of the federally qualified health centers in integrated care. Better funding usually translates to better coverage, better reimbursement model, virtual appointments, the role of mid-level providers. This came also in your work, I think, about the coordination between medical and dental providers. Well, that's very difficult because we don't have standardized patient records. That's a huge barrier. We heard from the patients of how long it takes to get care, but also specifically the rural area challenges that exist, how mobile dentistry or mid-level providers can play a role. We heard about the role of missed appointments, and again, transportation, work, childcare, these are all barriers by the caregivers who need to deliver the care. And this is a really important one. Patients rely on community-based health workers to bridge the cultural and language gaps during these appointments. And so if the office is not able to provide culturally competent care, they perceive that as a barrier to accessing care altogether. And very clearly, we heard from providers that limited coverage can mean higher out-of-pocket costs for the Medicaid beneficiaries. We heard about the burden of enrollment, audits, credentialing, the reimbursement. We heard about the role of teledentistry and how it can close some of the gaps related to access to care. I talked about the emergency department, and people don't have access, then it's too late. They have to seek relief somewhere else. And then the better communication between the dental and the medical provider can lead to good oral health habits and overall positive outcomes. I think that's something we heard very clear from the providers is they want these outcomes. The coordination is very difficult. I want to level set an understanding about the national healthcare expenditure. And while these numbers are from 2016, dental hasn't changed, and we're about 4% of national healthcare expenditure. What is one of the distinguished features is that the proportion of out-of-pocket spending when it comes to physician services is never more than 10%. But when it comes to dental, on average, is 40% and can be as high as 66%, meaning $66 out of 100 come out of pocket for accessing dental care. And I think I heard you say affordability was one of the key messages, and that out-of-pocket spending is a reflection on how challenging it could be to get these services. This is the total spending, the trends about the last 4 years. CMS spends about $22 billion. Here you see the dotted lines corresponding to the y-axis on the right and the solid on the left. But the reason I wanted to show them this way is to understand that in 2020, we all felt the impact of the pandemic. That was unavoidable, but that we all have recovered, both the private insurance as well as the Medicaid program. I think it's also very important to recognize where the highest spending happens in the public insurance and the private insurance space and the out-of-pocket. And it's really interesting to see where oral health resides. In the public insurance space, it's 34th and 47th. And again, the top 5 conditions you can see here, diabetes, etc. While diabetes remains in one of the top 5, look at where oral health is now, 11 and 12, much closer to the top. And it's number 1 and 2 when it comes to out-of-pocket spending. Again, I think reflected to your point about affordability of care. And people don't just have one condition. I mean, this is really remarkable, is if you ask how many people in Medicare have only diabetes, that's about 3% only. The rest have, 3 or more conditions, and 41% have 5 or more conditions. Now, coordinating the care, dental care and other care for 5 conditions, you can imagine how challenging this could be. And if you add any special healthcare needs or disability, that becomes even more difficult. And I think one of your interviewees said, oral health is really also about getting a job and employment. And with that comes a really important access to dental coverage. It is also about children, attendance and learning related to substance use disorder and, of course, all-cause mortality. So let me just highlight a couple of really good points that we have made great progress when it comes to children. These are children on the top that live about 400% of the federal poverty guidelines, and these are children who live below the federal poverty guidelines. The gap has closed, but remains pretty significant. Almost no change for adults, and the gap for seniors is increasing. And if you look at the racial disparities here, what's remarkable is that the gap is smallest for children, which is really great, but it increases when we go to adults and seniors. And if you look at the geographic variation of how many children had an oral exam, again, you would just appreciate how different it is. In some states, less than 20% of kids have access to dental care, and others close to 70%. So really important to understand that the environment is very different and the access to care. I mentioned the role of the caregiver, and we will wrap up with this, how important it is for parents to have access to dental services. If the parent had a dental visit in a given year, chances are their child will have a dental visit. And very few children won't make it to the dentist. But if the parent didn't have a dental visit, a lot fewer children go to the dentist and a lot more don't go to the dentist. Again, children cannot drive themselves to the dental office. I can tell you this, right? We know that the caregiver experience is so important. And one of your interviewees mentioned their deep anxiety. So you can imagine if the parent had that attitude and experience, chances are they're probably not taking their child because they are translating that to the child. And just finishing up with the adults, the gaps here are bigger. We have about 19% in the racial disparities. The gaps are closing, but they remain, substantial. And we mentioned that if adults don't have access to preventive dental services, chances are they will end up in the emergency department. And dental pain is one of the top reasons of why adults walk out of the emergency department with an opioid prescription. I mean, did you know we play tag with urolithiasis? This is kidney stones for a reason of walking out from the emergency department with an opioid prescription. And again, just to highlight that there is a huge geographic variation on the number of people who end up in an emergency department. Here, the darker blues are lower numbers, so that's better. The yellows are the highest rate. And the way you would read this is in some states, about 4% of Medicaid adults will end up in the emergency department for a dental issue. So I think it was very clear that there were a lot of alignments, and it's wonderful to see that reflected in the voice of the people you work with.
Thank you so much. Thank you so much, Dr. Chalmers, again, for sharing your expertise, but more importantly, your leadership at CMS and your ongoing efforts to bring oral health back into the body and connecting the dots. So with that, we have about a little under 20 minutes to answer some questions that we have from our attendees. Again, for those of you on the webinar, please use the Q&A option to share or ask questions for Blair, myself, Dr. Chalmers. I'll be watching the Q&A box and bringing up your questions, but we did have a few that came through our registration. And with that, I will get with the first question, which is, how can we further educate on dental care and how can it be made more affordable and accessible for our communities? Dr. Chalmers, any reflections, or if I have to, I do want to give a shout out, like we don't have to do something entirely new. We have to build upon what's currently happening. And I think in Texas, we are fortunate to really have a strong network of school-based mobile dental programs, school-based programs, both public and private. And I think that's a wonderful window for introducing or encouraging children at a very young age on the importance of oral health, but also sort of helping them visualize a good career option. I think I would start there and some opportunities there. And also there are several local, state, national resources that can be leveraged before we invent or develop new ones, but interested in your thoughts.
Yeah, thank you. Absolutely. And I think the schools are such an excellent place for not only educating about the importance of oral health, but actually delivering some of these services. Because as I pointed out, the parent doesn't have to take time off work, deal with transportation or childcare for the other children, and the child can receive the care they need. And related to this, I'm really excited to share that CMS announced $50 million in grants to deliver critical school-based health services to children. And 20 states will be awarded these grants to strengthen the enterprise, what's necessary at the state level to happen for these services to be delivered. The focus is to really enhance behavioral health services, but oral health services are not excluded because you can imagine many of the children who need behavioral services also may have oral health problems, unidentified oral health problems, right? They're acting out and nobody really knows if there is a pain or infection or two that needs to be addressed. So really, we will share the link in the chat. I hope all the states will take advantage of this opportunity to strengthen the school-based programs because they could address the education of the children, also interacting with the caregivers. And on a national level, I couldn't agree with you more. We should not be reinventing the wheel. We don't need another, resource development. Thank you, Cody, for sharing the link for the HRSA, very comprehensive, very thorough guide and toolkit. The Health Resources and Services Administration has put a lot of effort to make this as easy to understand, available in multiple languages, customizable. So no need to develop new materials. For me, it comes to who needs to hear the message. And is it lack of education or are there other barriers? Because I have heard many times from my patients that it's not that they don't recognize how important oral health is. They just can't take 3 hours out of work, even if they know how important it is. But again, any educational materials to the children, to the caregivers, in a culturally competent way that addresses their linguistic needs can help us get there, so that both children, caregivers, administrators at the school, and providers on the same page. One of the top reasons why children miss school is toothache. I mean, that is preventing learning. They're not learning about math or English, they're in pain. And so I think that is bringing the value of oral health to address, the other priorities that a school system may have.
So wonderful, and appreciate the opportunity that CMS is offering to again strengthen and invest more into, if I may say, catching them early. So again, appreciate that. Another question we received, Dr. Chalmers, was how do language barriers affect oral health equity, and how can we solve those issues? Any thoughts?
Yeah, it's interesting to see that first pop out in our human-centered design, the culturally competent care. But we have heard loud and clear from providers that they now have to hire staff that can address the linguistic needs of their patients, right? That's one way of doing it. But I would say, if you look at it from the perspective of the patient, if you really don't understand what's going on or what's the need or how to prevent the disease, how can you be engaged in your care? So that is, from the patient perspective. And I think from the provider's perspective, can we truly, have informed consent if we're not able to deliver this to the patient in their language or help them understand what the needs are? So it comes to a very basic concept of like informed consent, understanding what the needs are and how some of the cultural norms may impact perceptions about oral health or behaviors. I mean, I've had many patients who said, we're just not going to drink, tap water. We like bottled water. So that's a cultural driven behavior that can have huge impact on the oral health of the children. And so understanding that, working with the parents of how to motivate them and understand that this water is safe and that their children's health can be improved. This all comes together and it has to be delivered in a competent and cultural way.
Couldn't agree more. And again, as Blair lifted out, like, again, part of this is what we think is more of like a good to have. It's just a matter of time. It's going to be a necessity in Texas as we look at both, not just the increase in our population, but the diversity that the makeup of Texas population demographics. It's going to be very different starting in the next, actually starting this decade and going over the next few decades. So what is a desire today is going to be a necessity before we know it. So I appreciate that and couldn't disagree. Another question we received was, how do we or how does one influence the question was insurance company. I would think that it was rather frame it as a managed care organization or a payer broadly to receive or to help increase the reimbursement rates through Medicaid.
So this is an interesting question. And as I said in the beginning, in general, states establish how they pay providers within federal requirements. And according to federal law, Medicaid payments must be consistent with efficiency, economy, and quality of care, and has to be sufficient to provide access equivalent to the general population. So these are broad guidelines. And CMS has been taking actions to help ensure that access to care in the Medicaid and CHIP programs, including oral health, includes proposed access standards, right? And payment rate transparency measures, as well as strengthen engagement with beneficiaries and other stakeholders. So I think to your point is knowing how big is the problem and where the pain points are, but also having standards in order to ensure this access to care. We had multiple comments submitted in our proposal to strengthen this and encourage, again, everyone to remain engaged, share their perspective, and provide feedback. I will share with you that I have had the wonderful honor and opportunity to meet with many oral health stakeholders at the different states, close to 40 now. And the picture is a little bit different in every state. And even in the states where they have seen significant increase in reimbursement rates, the other problems don't go away. So I'm not saying it's not important. Absolutely, reimbursement rates are very important, but they're not the only solution. This is a very complex issue. And as you saw, just from the examples I shared about the interaction with children and caregivers, and if you have children with special healthcare needs or developmental disabilities, right, their needs don't necessarily change with the fact that now the reimbursement rate is bigger. Hopefully there will be more providers that they can call on and see. But I was really moved. I think it was one of your interviews, Amy, who said in the end of the day, she wanted to feel heard and respected. And I think this goes back to the linguistic barriers, right? How can you really be heard and respected? How can you see a provider if their door is not open? And so it's a real interplay of all the factors in order to ensure that people have access to dental care early and not only when it's an emergency.
I appreciate that. And something I would like to echo more of what you said earlier is this is an ongoing process. It's not determined a point in time. It stays as a constant. It's an ongoing process. Texas legislature reconvenes every 2 years. That's your opportunity. And I encourage educate both the payer, but we collectively have an important role to educate our legislators. We think they know this, but unless and until they hear from us and many of us, they are probably not going to have all the questions answered to be able to say that I grasp it and this is what needs to change. And it's an ongoing process and one amongst many priorities or solutions that are required to ensure access. So Dr. Chalmers, have to echo your question. I'm now going to turn my attention to questions we are actually receiving while we speak. So in the Q&A, the first I see is, can you expand on how dental care can be part of medical care for all? Dr. Chalmers, I'm happy to give a quick reaction and will invite you to chime in as well as Blair, but this is not something that we need to start doing from now. It's important to recognize it's already happening. Time and again, I have been inspired with the innovation around medical dental integration into professional collaboration, especially in our federally qualified health centers here in Texas. And I think the idea is how do we achieve scale, but more importantly, how do we not just keep this limited to a few settings, to a few populations? How can this be more of a norm rather than an exception is what my takeaway from this conversation is, or what I hope and intend that THI would focus on. But again, welcome your thoughts, Dr. Chalmers.
Thank you. And I think it's a really great question. I would love to hear Blair's thoughts on the reflection from the people you interviewed. But let me give you two examples that, to your point, Dr. Sangavi, are not fictional, are already happening. The first one has to do with very young children. So we know the majority of 1-year-olds, 2-year-olds, they don't go to see the dentist, but they most likely will see their pediatrician. And so it's a huge opportunity for very early communication with our pediatric colleagues to talk about oral health, and not only talk, but integrate oral health prevention in the primary care setting. We actually completed a 2-year learning collaborative with 14 states where their single goal was to improve the fluoride varnish application in a primary care setting. And it is remarkable to see how much progress in the background of the COVID pandemic the states made. I'll just highlight one. They were so modest in their initial, efforts to do this. Like, this is very difficult. Everybody's doing 20 million things. One more thing is too much for the workflow. So they said, let's just, aim to improve fluoride varnish by 2%. What was so wonderful is because they used the principles of quality improvement, the planned use cycles, they were able by the end of the learning collaborative to improve fluoride varnish by 18%. So not only it's possible to do it relatively rapidly, right, in 2 years, but it requires a real understanding of the size of the problem. Data is really key, and data for quality improvement, it's another conversation we can have. It has to be actionable, it has to be quick, so they could react to it and change behavior plan, etc. But that's a really great example where we see it today, and not only pediatric providers are doing this care, now it's reimbursed by most states, right? I think that's always one of the challenges. Well, if it's not paid for, why should they do it? But now at least the fluoride varnish for children, it is. And then the other very exciting area is OBGYN clinics are now integrating dental hygienists in their practices because they recognize you cannot be a pregnant mom and have a mouthful of cavities or infection and not address that in any shape or form. And mom can go to yet another appointment. So they're integrating care, maternal and oral health care together. So truly remarkable. And I think the best is yet to come of how and where innovation will lead. And I would say it's bidirectional. Many dental providers are measuring regularly high blood pressure. Of course, they're monitoring for A1C. So it goes both ways. But great question.
And if I could just echo what Dr. Chalmers just said, it was consistent with our findings that there was a call and a strong desire to have that integrated dental and medical care for well child visits, for prenatal care, not even just prenatal, but before, during, and after care, because that just establishes that relationship and importance of oral health, not only for mom, but also for baby and the family. As we know, that moms are often the health decision makers for the family. But the second thing I want to mention, and I know we're running short on time, and I just want to give a real big shout out and just a reminder that when we seek solutions to these problems, we really ought to engage the community in doing so. And that we need to co-create solutions, and that allows for action and sustainable action. So for those, I see there's several questions that we may not be able to get to in today's time, but we will, of course, follow up with those questions later. But just to call that many of the solutions to the questions are often in the community. So engaging the community and sustaining relationships in the community is the path forward to integrating and delivering care.
Well, thank you so much. Again, I want to be, we have less than 2 minutes and want to be respectful of everyone's time. So as Blair mentioned, we do have a few more questions, and while we'll not be able to address or answer each one of those, please stay rest assured that we will get back to answering your questions. And we encourage you to, again, reach out to us. And our contact information is being shared in the chat for both Blair and I for any questions you have on our report or the work moving forward. Again, I encourage and welcome your ideas, your inputs as part of our ongoing efforts. But one of the questions or comments which I can give a quick response to is on the impact of SB 17 that was passed last session here in Texas, with a focus on DEI. I invite you to please review the report, because I think the value that this has to offer has nothing to do with the intentions of the bill that was SB 17. In fact, this is this takes it out of the political discourse. If we have to depoliticize oral health equity efforts, I think this report has been a wonderful example in terms of the stories we have heard, the solutions that are needed, and that if we pursue those solutions, you will see changes when it comes to access, when it comes to affordability, when it comes to achieving oral health and health outcomes for the populations we seek to serve. So again, appreciate that comment. And from our perspective, we don't see this as a challenge. We actually see this as a resource and a way to guide your oral health equity efforts moving forward. With that, we are at the top of the hour. Again, my sincere appreciation, Dr. Chalmers, for your expertise, sharing your valuable time with us, and continue leading the charge for us nationally. Count on us on anything we could do to support your efforts. For those who have joined us today, we hope you enjoyed the discussion. Again, we invite and welcome you to review the report, reach out to us with your ideas. Heartfelt gratitude and appreciation to our community-based organization partners, those who were part of the key informant interviews. Definitely the team at Texas Health Institute that made this possible. And again, a huge shout out to our funding partners at CareQuest Institute for Oral Health for their critical support in pursuing this work. With that, we'll sign off. Thank you for joining us.
Thank you, everyone.